I'm very honored to be part of this 10th conference on tropical medicine and international health. And I'd also like to say a big thank you to my senior colleague, Dr. Bethune, for this kind invitation that has been extended to me. Today, I just intend to share some of the work that we have done, not just in Ghana, but across the Africa region. And I would borrow a little bit from some publication that has been done by the Lancet Commission looking at the future of health in Africa. And I would also focus on Project Fives Alive, which was a specific large-scale initiative that we undertook in Ghana, and then share some of the lessons that are emergent from that, and ultimately talk about some forum that we are organizing in South Africa next year to celebrate the work that is ongoing in Africa. I work for an organization called the Institute for Healthcare Improvement, familiar to some of you, but perhaps not known to the rest of you. It's based in Boston, in the United States, and for 25 years has been leading in quality improvement initiatives globally. IHI has a mission to improve health and healthcare worldwide, and I am privileged to be leading the Africa work. And for 10 years, we've been working through many countries, starting initially in Ghana, South Africa, and Malawi, but now with large-scale initiatives in Ethiopia, in Nigeria, and a host of other countries, about 13 in all. And the work continues to spread, and we continue to learn, and we continue to adapt in the work that we are going in the fields of maternal and child health, in HIV, in tuberculosis, in training, capacity building, and a host of other initiatives that are ongoing. Now to the Lancet Commission publication that came out this year, examining the future of health. They talk about the double burden of disease that we continue to see on the continent, the transition between the traditional situations like malaria, HIV, tuberculosis, maternal and newborn health, to emerging challenges like the non-communicable diseases, maternal health, injuries, and difficulties that are emerging from environmental changes, and then the scourge of the climate change. Progress has been made on a number of the health indicators, the Lancet Commission observes. If you take Ghana, for example, between 1990 and up until now, maternal mortality has been halved. The last demographic health survey that was conducted showed that child health had been reduced in terms of mortality by up to 25%. But these improvements notwithstanding, we see a certain reduction as far as improvement is concerned between life expectancy and then the population health indicators, in that we are still lagging behind the figures that are being shown in population health outcomes in low and then middle income countries. There's a challenge in Africa as far as we are concerned, because you see that there's a huge young population that is expected to grow to about 450 million by 2030. So if anything is supposed to change as we move forward in the challenges that are confronting us, we would have to be able to carry this young population along with us. So the recommendation has been for African-based solutions led by African scientists working in partnership with the global community using homegrown solutions. And hopefully today, I will be able to share some of that. And the vision outlined in the Commission's report published this year is that Africans should have the same opportunities for long and healthy lives that new technologies, well-functioning health systems, and good governance offer people living on other continents. And a key thing that I'd like to draw attention to is that out of 8 action plans that have been outlined in the Commission, they talk about innovation in products, service delivery, and governance. What would it take to attain this future that has been outlined? And the interesting thing is that when one talks about the challenges that are confronting us, when one looks at HIV, when one looks at malaria, even from Umberto's presentation, when one considers tuberculosis and the newborn deaths, there's an amazing amount of evidence that is available. And if we were only able to apply this evidence, there would really not have been any problem. We have antiretrovirals, we have medications to treat malaria. If you talk about the stagnations that many countries in Africa have observed, as far as newborn deaths are concerned, we know that 75% of newborns die in the first week of life. We know that 50% of them are dying in the first day. So much is known, and yet the knowledge is not being reliably applied to get improvement in the health outcomes as we would like. I like to make reference to this evaluation that was done on an accelerated childhood survival and development program that was undertaken in West Africa. An expansive 5-year initiative, and yet at the end of it, looking at the countries where the intervention was undertaken and those where nothing was done, they found that there was no significant difference in the mortality decreases in the intervention and non-intervention areas. There were mixed results as far as coverage of high impact interventions were concerned, no significant improvements in the nutritional status, and a host of other findings that came up after spending so much resources in carrying out these initiatives. So what then will it take to apply the evidence that one has, not just in a small setting, but across, an entire nation, and in some instances across the entire region of Africa? The first observation that was made as far as this accelerated childhood survival program was concerned, and in the observations that emerged, was that there was poor coverage of effective treatment interventions for malaria and pneumonia. So although the treatments were known, although the evidence was established that you could use artemisinin-based combination therapies to treat, there was poor coverage. As far as large-scale implementation is concerned, the implication was reliability. How reliably are we implementing the evidence that we know? They talked about the causes of newborn deaths and the undernutrition not being addressed. So once we knew so much evidence about the causes of these mortalities, the clinical evidence in some instances was not applied at all. Then there were issues around shortages in the stocks of medications. So often in many of the programs that are implemented, the evidence is available, people begin to implement, but then they forget about the system barriers, issues about procurement, issues about management, issues about leadership are all not brought on board, and then the programs fail not because of lack of evidence in the efficacy of the interventions, but because we do not adequately factor in the system improvements that one needs to take care of. And this is where I come to the specific project example of Project Fives Alive, which we undertook in Ghana, how we went about it, the lessons that we learned, and the results that we got from that large-scale initiative. So Project Fives Alive was an initiative of four partners: the Institute for Healthcare Improvement, the Ghana Health Service, the Catholic Health Service, and the Ministry of Health in Ghana. And it aimed to support Ghana as a country to reduce under 5 deaths, aligned, of course, to the MDG goal. It was a project that was funded by the Bill and Melinda Gates Foundation, and the key thing was the application of quality improvement methodology to accelerate improved health outcomes. And it happened between 2007 and 2015. It was a large-scale initiative, and what we did was to select 3 initial districts, and ultimately we moved from 3 districts to over 100 districts. We worked in an initial 9 hospitals and ultimately scaled up to a large number of hospitals. But the advantage was that by starting in 3 districts, we learned about what worked in a real system, what it takes to overcome the barriers that I mentioned earlier on, and what it takes to actually improve health outcomes. And so the project was, implemented in waves. Wave 1 in those 3 districts, wave 2 scaling up to 38 districts, and ultimately doing a national scale-up. We started with a content theory by asking ourselves, what does it really take to reduce deaths among children less than 5? And there we had what we called the key primary drivers. We looked at delays in seeking care, what it takes for them when a mother's child falls ill to come to the hospital very early. And we said that in some instances, even after they have come, we do not treat early. So we said the second key driver would be delay in providing care. And then even when we provide care, are we always reliably applying the treatment protocols? And that led us to the third driver, of inadequate application of the treatment protocols. So these were the three drivers. And for each of the primary drivers, we came out with secondary drivers. So for example, for delay in seeking care, we would say that there are a lot of sociocultural beliefs and practices that prevent acutely ill children from being brought to the hospital early. For delay in providing care, once they hit the facility, we saw that there are certain delays. We are not having effective triage systems that are in place that help us to be able to quickly identify critically ill children for prompt care. And then for reliable use of protocols, not everybody actually knows the protocols that are supposed to be used. And so you find out there's a lot of variation in the way one clinician manages from the way the other clinician would manage. What was the methodology that was used? We used what we called an improvement learning collaborative, which some of you, I'm sure, are aware of. But then this simply helped us to create a peer learning network. So we took the high burden hospitals, recording the highest amounts of mortality, and put them together. Taught a number of quality improvement tools so that they could diagnose their own system and process failures, brainstorm to generate ideas, and then to go back to their health facilities and to test these ideas in a real system. And we defined indicators to be able to assure ourselves that we were recording improvement in all the primary and secondary drivers. So these teams, mainly made up of hospitals, would come together every 3 to 4 months. They would share their ideas, they would share their data, they would review their own local performance, and it was not really up to a manager at the regional level or the national level to tell them whether they were improving or not. They could review their own data and make meaning out of it. And over 18 months, we got some very interesting results. So just to give you an example of some of the changes that were happening. This is a hospital that had about 80% of the mortalities happening as a result of malaria. The evidence for what drugs to be used to treat malaria was known, as I keep saying. The question was, how were they going to reduce it? And if you look at the first part of the graph, you see the unreliability in adherence to treatment protocols, which means that so many children were dying from malaria, but it was not in every instance that we were applying the correct protocols 100% of the time. So then this doctor here is the head of the quality improvement team that was formed within the facility. He now took it upon himself to use his ward rounds to build capacity within nurses, to build capacity among lab technicians, to be able to diagnose promptly and to be able to treat correctly. So you see very clearly that over time, there's almost 100% adherence to the treatment protocols as far as malaria was concerned. And in this particular hospital, over the 18-month period, they reduced under 5 mortalities by 60%, just by these very simple interventions. This is also a very interesting slide. This is a community health officer. This is a community-based assistant or a community volunteer. This is a traditional birth attendant. And the problem that was identified, if you recall, the first driver was that there was a delay in care seeking. So these three are coming together within a learning network. And it's not often you see health professionals interacting with community actors in this way to map out the process. So they drew a simple process map. What happens between the time a woman goes into labor and the time she actually arrives in the health facility? They diagnosed the various barriers, and that helped them to come up with innovative ideas to be able to drive change. In some instances, what was said was that the women were delivering in the communities because in the communities they are allowed to squat. In the hospitals, they are made to lie on their backs, and some of the women did not like that. So all it took was to be able to make it possible for women to squat if they so wished in the facilities. In one other community, they said that women deliver in the community because when they deliver, they are given a hot drink. In the hospitals, you don't give the women hot drinks. So all it took to be able to push skill delivery rates up was for the facility to use its locally generated funds to provide hot drinks, hot porridges to the women and they felt much more comfortable to be able to come and deliver in the hospitals. Simple interventions. Here, I just tried to provide a summary of many of the changes that happened. Where you had an ambulance to transport women and children, that was fantastic. But in some communities, this is a taxi, a public taxi, privately owned. But then it took the community to mobilize, sometimes to put funding aside, so that when the woman went into labor, this taxi driver would take the woman promptly to the hospital to make sure that there was no further delay. And a host of other innovative, simple, low-cost interventions that were deployed in Project 5's Alive. So at the end of the day, we use data to rigorously analyze the effect of all of these changes and to develop what we call a change package. This change package then contained very high impact changes that had been found to have led to improvement. So I talked about the three drivers: delayed care seeking, delay in providing care, adherence to protocols. And these are the various ideas that had been found to be implemented and to have led to actual improvement within those various facilities. And that is what we use for the scale-up. So from testing in 9 hospitals, we moved to 32 hospitals, ultimately scaled up the change package to 68 hospitals, and by the time the project had ended, this low-cost, innovative ideas had been scaled up to over 200 hospitals in Ghana at district and then regional levels. I'm sure you're asking yourself what the results were. These were the results after the national scale-up from the initial 9 and when we went to the 140 hospitals by August 2015. Under 5 mortality, facility-based, under 5 mortality rates had reduced by 35%. Post-neonatal infant mortality rates had reduced by 54%. Malaria case fatality rates had reduced by 38%. No new wards had been built. No new doctors or no new nurses had been sent to these facilities. No neonatal intensive care units had been put up. But these were the kinds of innovative, galvanizing community efforts, testing reliably and implementing in a way that made sense, that had led to these phenomenal results. So what are the lessons that we have learned and would like to share from this work? The first thing is that a good policy environment enables environment. So in some of our more recent work in Liberia, in Malawi, in Ethiopia, in Ghana, you find out that we are working in partnership with the Ministries of Health to develop and to launch national healthcare quality strategies. And these quality strategies are now given a framework within which these quality improvement initiatives are done, so that they stop being project-led activities and actually driven by national health systems to be able to improve our chances of sustainability. The second thing is that once one develops these policies and says that this is how the country wants to go, the second issue has to do with capacity building. So in many instances, capacity of existing people employed by the health systems are built so that when a small project team departs, the country can continue to implement. If I look at the example of Project 5's Alive, the entire project team was less than 25, and yet we succeeded in doing the national scale-up. And the reason that was possible was because there was extensive capacity building. Over 400 quality improvement coaches were trained, leading the work directly with the project just providing support. And so now all of those officers continue to be available to the health system to work, although the project itself is no longer in operation. I can't say enough the lessons that we have learned from testing from a small scale of the system, adapting to various settings, and then scaling up. But really, that is what we did. A lot of the time, I know there's an enormous amount of pressure to scale up. People say the evidence exists, let us just scale it up nationwide. But you do not often take account of the system barriers that you would come across, the issues around stock out, the issues around lack of management and leadership support. And often when one tests in a small scale of the health system, you begin to learn what it actually takes to implement reliably in an existing health system. And that is what we have learned over this time. The next question that I would ask, when there's a lot of pressure to scale up, is that what exactly are you scaling up? And what evidence have you built from implementing in the health system to say that you are scaling up? So this is where it is helpful to test, learn, document your learning, and then you can then scale up an evidence-based package that would make difference. The other thing that we have seen is that there's often a tension between whether to build a parallel data system or to rely on the national data set. We decided that we would work with the national data set. Of course, there are data challenges. And so what we did was to be able to develop a protocol to be able to improve the completeness, the timeliness, and the accuracy of the national data system so that we do not have flawed national data systems and then only reliable project data sets. So if we work with the national data systems, but we continue to improve the quality of the national data system, by the time we are done, the country's data system overall continues to be strengthened. And then, of course, we have data that shows that in areas where we had strong community engagement, antenatal attendance was much, much stronger. The results were much, much better. So the lesson being that it is important to involve communities in this type of work so that we can get enduring and sustainable results. In many places, as we have come to see, trainings are typically about taking health workers from their facilities to go outside for long periods, long duration trainings, and we have found that they haven't been very helpful because often you are only able to train a limited number of people. You train 1 or 2 people who come back to the facility and are not able to effect change among their colleagues. So increasingly, through some partnership with JAPIGO, we rolled out a low-dose, high-frequency training. And what that meant was that the trainings were delivered in small packages. They were facility-based. They were very practical. We had simulators to be able to carry out the training. And they focused on the training needs of the participants within the health facilities. And we could train all the midwives, we could train all the nurses within the facility, and we realized that that gave us more confidence for how these would then be implemented going forward. And it wasn't a question of 1 or 2 people having the skill, but everybody within the facility having the skill to be able to implement in the treatment process. So this was also another key learning, competency-based, case-based, and very practical. So I'm beginning my conclusion slides. And we believe that once we learn a lot from the ways that I have described, we would be able to innovate in an applicable context. We would be able to scale, and we would also, with the capacity that we would have built through strengthening national data systems, we would be able to sustain. And in many places that I've been to, I know that in Namibia, they are using this collaborative method and these innovative quality improvement approaches to improve retention in HIV care. In Abuja and also in Lagos, they are using these similar processes to be able to improve care in pediatric HIV. In Ghana, similar processes are ongoing to test how we can adapt these technologies within an existing health system. And all over the African continent, innovative work is happening. And I would use that to draw attention to the Africa Forum on Quality and Safety in Healthcare, the first, which is happening in Durban in South Africa next year in February. And this will be an opportunity really to showcase this work that I'm talking about. A lot of keynote speakers, a lot of abstracts, a lot of oral and poster presentations that will then show the full scale of the work that is happening in many places in Africa. So again, if people are interested in attending, I'll be happy to continue to engage with you. But the fact is that there's a great momentum for change and for improvement in the African continent, and I believe that the work that you're doing here is so significant and ties in very clearly to that momentum. Thank you very much for inviting me.